Welcome to Health Alert. I'm Pam Butler. Today we're going to talk about the Greenwood HealthCare Specialist for Women, and joining me is Dr. Calvin Monroe. Welcome to the program.
Nice to be here.
Now, I want to, before we start, you're an OBGYN.
Correct.
So tell people exactly what does an OBGYN do so they have an understanding when we start talking about the healthcare facility that you own and operate, what the services are. What is an OBGYN?
Well, it's sort of short for obstetrics and gynecologist.
Okay.
The obstetrics part of that title is a doctor that delivers babies or takes care of women during the time of pregnancy. A gynecologist is one that basically takes care of women in every other ilk or realm that there may be illness or problems. I mean, there's some limitations depending upon what specialized training you get, but the general obstetrics and gynecologist pretty much takes care of the woman in almost every aspect.
Okay, now what age do you start to focus on women? How young? And then I assume it goes all the way through the life cycle, but how young?
I'd say for most obstetrics and gynecologists, we take care of them either at the age they become pregnant or at the age they start menstruating. A lot of times, most of that responsibility I'll say responsibility falls on the pediatrician. They'll take care of them until they're at least out of their adolescent years, but sometimes they'll refer to us. Other times the patients will come to us even as early as 13 for problems with menstruation and or pregnancy. Okay.
Now, you have an exciting new facility. It's called the Greenwood HealthCare Specialist for Women, right?
That's correct.
Now, tell us about this center. I'm so excited about it and where you're located, and sort of start with the vision of why did you want to do this?
Well, actually, it's been a dream of mine since, as far as I can remember, actually. I set out with the attitude that if man can do it, I can do it. And so I started dreaming big at a very early age, and I was like, well, what's the biggest thing I can do? And I was like, well, didn't want to be president, but I figured either doctor, lawyer, or something like that. The lawyer aspect, it was quite a bit of writing. I wasn't interested in that. So I started pursuing being a physician, and as a result of that dream, I started getting guidance, mostly from my mother, as to where I wanted to end up. She kept putting a bug in my ear about delivering babies, and I kept saying, yeah, Mom, whatever, you know. But as time went on, as I started getting exposure through residency, or actually through med school, you start finding things that you do want to do, things you don't want to do. Obstetrics and gynecology offers everything for the most part. You can do primary care, you can do surgery, you can deliver babies. It actually is a full spectrum of things you can do, so it never gets tedious or laborious. Laborious, I shouldn't say. It does get laborious, but it's not tedious or boring in that regard.
Okay.
I'm not sure if I answered the question, but
okay, you're getting there because you're talking about how you even start to focus in this area. So you started with that kind of dream, and then how did it roll into looking at this healthcare facility that you have? Because you didn't work in independent facilities like this before, or did you?
Actually, my mother started out very, very ambitious herself, and she started getting into a lot of HUD homes back in the Chicago area, and her family everybody was kind of entrepreneurial type spirit, and so that sort of spirit carried over into me. As I started growing up, I started thinking, well, it sounds odd, but I was thinking, well, I laid out a list of dreams. One of the 6 things I was going to do was, the list was basically become a physician, own my own practice, get a pilot license, retire off my investments, get an MBA. So I did everything but the pilot license and the retirement off the investment thing. But getting the facility kind of came, wanting to own my own building and my own practice. All that sort of came out of, that's what my mother fostered into me at a very young age. And so growing up I guess I came to Tulsa out of an obligation to work in an underserved area through a program called the National Health Service Corps. Once I got here, I had a time commitment of about 4 years. I came with the idea of basically giving that 4 years and moving on. As I came here, it became a natural fit. It was a community very similar to my own growing up. I was given the charge when I decided to leave. My family told me that if we're going to leave, we're going to find another place that we plan on staying for the long haul and until the kids were grown and out of college. And I was like, well, when I started looking around, I was like, well, I see no other place better than where I'm at currently. And as I started looking around to see if there were places that I could actually set up my practice, I really liked the community and found the community that I was serving while I was serving that time commitment. Found a great spot, getting ready to go on to the auction block, and jumped in with a bid, decided to take it before they got to the auction block, and ran from there. I mean, it was kind of a daunting task at first, but as it began to snowball, it became more realistic.
Okay, and like I said, it all started with a dream, and I think that's really important for people to hear and to understand, because if you don't dream, you may not reach certain goals. So you have to start with that kind of vision. Now, where you're currently located, and we will put up information at the end of the show of where you're located, but where you're currently located, like you said, it's a really underserved population with a great need. And that was something that sort of drew you to that particular area.
Yeah, I mean, I guess as an entrepreneur, as a person wanting to contribute to this thing we call life, I guess, leave my mark before I go, I wanted to be able to do something that would carry my name on. And quite honestly, there was a great need. There's really no specialized physician care on north of downtown. There's a few primary care physicians. I think there's a neurologist, and that's pretty much it. And I guess, and I may be wrong, but from what I could tell, from downtown to I can't think of the first neighboring city, not Owasso,
Turley.
but Turley. I don't think there's a whole lot of physicians in that area.
Right.
And so a lot of patients will find themselves traveling to downtown or South Tulsa or even Owasso for care, and it's like, I didn't see why. I mean, I felt like if I had this aptitude and I had this capability, and I mean, I said I served the community, I had the means to make it happen. Okay. I didn't see why I shouldn't make it happen. So. Okay.
Now, in your practice, then, do you have the full scale of services available? What can people expect? Women, how young can they come to you? And then what kind of services do you offer?
They can come to me. Again, like I said, I see a lot of them probably at the time they first start menstruating. Usually, if they're 9, 10, 11, I may refer them to the pediatrician, unless it's beyond their scope. But from the time they start menstruating until the time they stop, or even beyond, I'll take care of them. And the scope is pretty full spectrum. The only thing, from abnormal menstrues to hysterectomies to tubal ligations to cesarean sections to vaginal deliveries to colposcopy, pap smears, cryotherapy, LEEPs. A lot of those services I provide in-house. More of the major surgeries like hysterectomies and cesarean deliveries I'll provide at one of the major hospitals.
Okay, where you have privileges for
Correct.
Those. Okay. Now, with this, do you also have a full-scale lab at your site, or is it where there's lab work done and you refer it out, or for lab work the person has to go someplace else? How does that work?
Well, I actually had the luxury of making some connections with a lab called DLO, and they actually provide pretty full spectrum laboratory services, not in-house, but there's a draw site within the facility itself. Okay. So they can get their blood work done there. Whatever biopsies that I take there can be sent out to the pathologist from that site. They don't have to go. Now, it is convenient in the sense that DLO has several draw sites throughout the city, so if they can't make it, or if they can't stick around, or if they come during some of the hours that I provide, which are a lot of times late, when the lab tech is not there to draw the blood, then they can go most anywhere in the city where there's another draw site. Okay. We just put the orders in, and the orders will carry over. Wherever they go, they'll be able to pick it up on the computer and draw the blood for whatever service or whatever lab we want it done that day.
Excellent, excellent. We're going to take a really quick break, doctor, and then come back and talk about some specific services in terms of like women's physicals and what could they expect and what do you do. Okay, stay put.
All right.
And you stay put. We'll be right back.
Learning how to kickflip 6 stairs takes determination. So will getting into college. I've got what it takes. So do you.
Welcome back to complete, or rather continue our discussion talking about Greenwood Healthcare Specialist for Women. Joining me again, Dr. Calvin Monroe. Let's jump in. Okay. Now, the facility that you founded and started is very exciting. I want to get into some more details of it. Let's say a woman's physical. What does that look like? What should women expect if they're going to come to you for a physical?
For a well-woman exam, that pretty much is a complete physical from head to toe. You think of obstetrics and gynecologists, a lot of times we focus on just the reproductive organs, but in general, you know, we'll listen to the heart, lungs, we'll do a breast exam, examination of the abdomen, to see if there's any masses or tenderness. We'll do the pap smear, the pelvic exam to see if there's any pelvic masses or any obscurities that don't belong. Look at the skin overall to see if there's any abnormal lesions on the skin, and from there well, prior to that, we'll take a full history, trying to see if there's any chronic medical illnesses or prior surgeries or allergies to medications or fear on medications, and then we'll get into the physical exam itself. In the end, the aim is to try to promote well-being and health, providing prescriptions if needed, providing suggestions or recommendations towards various screening exams to help promote health. Things like colonoscopies, repeat pap smears, mammograms.
Now, let me ask you this: for the mammograms, do you refer out? Let's say with the breast exam, you don't detect a lump or anything. Tell us how that should look for women, that you should still have a mammogram, and do you refer out, or are you connected with a certain service that does the mammograms?
Well, we actually we do the breast exams. That's the first part of the actual screening, and then from there we usually will use most any of the hospitals. It's usually the patient's choice as to where they want to go. I use Alita Chapman a lot in Hillcrest Hospital. I do affiliate with Tulsa Project Women, and we do provide breast exams exclusively, just the breast exam, for somewhere between $10 and $15, and from there, if the patient qualifies, they usually can get a coupon for a free mammogram. And so, but yeah, I usually refer it out to the actual imaging process part of it to any local hospital that the patient chooses. Okay.
Now, how often should a woman, and at what age, think about a mammogram? What do you recommend?
It really depends on their history. A woman in general should probably have a screening mammogram about 10 years earlier than whatever first-degree relative they have that has had breast cancer. If they don't have any relatives, first-degree relatives otherwise, with breast cancer, then the average screening age is about 40.
Okay. Now, when we look then at colonoscopy, and then I want to come back to pap smears, once again, that's a referral process, and when should women look towards colonoscopies, or is it based on what you may find or not find, or is there routine screening for it too?
That also depends on the history, family history, but just screening in general is about age 50, and that's for both men and women. The actual part of the physical exam that many women may not be used to, but should be provided with each annual visit, especially after the age of 40, is a digital rectal exam, where they're looking for occult blood or looking for blood that usually you can't see with gross examination, and it's a specific test that is performed usually in the office, and they may give you some cards to take home because you're looking for a serial examination of three stools in order, I guess I should say, where you're looking to see if there's a repetitive positive for occult blood, and that starts the process. If that is positive more than one time, then the actual colonoscopy should be recommended sooner.
Okay, and that's something that you follow up with. Now, with PAPs, how do they go? Because there's such controversy there has been about PAP exams and when to get them and what you do about them. So tell us about the current state as far as how you practice with PAP exams.
Well, I practice by the guidelines set forth by the American College of Obstetrician Gynecologist, and basically what that has currently come to mean is that most women earlier than the age of 21, we don't recommend having pap smears, and that I think comes out of trying to avoid exposing these young women to invasive procedures that may not be necessary, considering that their bodies are usually able and capable of curing any pathology or fixing any pathology of the cervix pretty readily. So they've stopped recommending doing it prior to the age of 21. Between the ages of 21 and 29, it's usually recommended once every 2 years, provided there's no abnormal PAPs. Okay. And between the ages of 29 and roughly 65, every 3 years. Now, saying that, the caveat is that they don't ignore having an annual exam, because we're looking for other things, possible masses in the pelvis, breast masses, just routine screening that should be done, that is recommended more annually than every 2 years or every 3 years. But in general, the PAP portion of the pelvic exam or the speculum exam should be done every 2 between 21 and 29, and every 3 between 29 and 65.
Now, how does that boil down, doctor, to, especially under the age of 21, for women who are sexually active? Is that still a recommendation that they still don't need anything until the age of 21, or does that indicate potentially there could be PAP exams that are needed?
Well, the actual reasoning behind not doing it under 21 is pretty in-depth. But if they're coming in, usually they're coming in for abnormal menses or birth control or STD screening. But the actual PAP portion is encouraged to not be done before the age of 21.
Still, okay.
Yeah, even despite when they become sexually active. And that's because of the knowledge that's been gained over the years with regards to the specific virus called HPV and how it actually works and how it actually influences abnormal cellular change.
Okay. Now, with the HPV, tell people a little bit about that, because sometimes people have heard that there is a vaccine available for that.
Yes,
what is it exactly?
Well, it's like any other virus that we come in contact from day-to-day living. I mean, some viruses we are able to acquire and actually are able to get rid of. Common cold virus we acquire all the time and get rid of it. But there's other viruses that kind of stick around and may wreak havoc on our immune system. Others may just cause some changes, such as what we see with regards to the cervix. Okay. This particular virus is one that's passed on sexually. It's very ubiquitous in the sense that I'd say 90%, 90+% of the sexually active population in the world has it. It's hard to avoid it unless you've always used due diligence and used a condom with sexual activity or practiced abstinence. But it's very hard to prevent exposure, and with the exception of the fact that they got now a vaccination. But the vaccination only provides protection against 4 of the many hundred strains of HPV. So it's the 4 most common strains. It is an effort to provide some protection from initial exposure, but it is definitely not the end-all of care. I mean, if a patient gets one of the viruses that are not within that 4, the chances of them having some abnormal pathology may be a little less, but it's not negligible. It's not non-existent.
Okay. Now, how young is this vaccine recommended? They
got it now in the pediatric immunization schedule, and I couldn't quote you. I don't really do a lot of pediatrics, but but it's in the schedule, and I think it's about as early as 13.
Right. It is very young, where people say, well, the child really isn't sexually active, but
and they're trying to get it before they become sexually active.
Okay, so that it can build up the protection. That's what I wanted to ask you. Why would there be such a recommendation in terms of what you hear in the medical community of advising people to have their young daughters vaccinated, especially if they're not sexually active, because it does build up the immunity?
I guess the problem is that we like to wear the veil sometimes, and I have young daughters, and we think that they're not sexually active, but the reality of it is I'm seeing 13-year-olds pregnant, I'm seeing 13-year-olds with STDs. And so they're trying to just get them at the point prior to them piquing that interest in the opposite sex and trying to provide the immunity that they I think, deserve against this particular virus that hopefully one day will become non-existent, such as polio has in some time past.
Okay. Well, we're going to take a really quick break and come back and pick up on a couple other conditions that are pretty common or that you may see in your practice and what we can expect. Okay. All right. Please stay with us. We'll be right back.
to kickflip 6 stairs takes determination. So we're getting into college. I've got what it takes. So do you.
Welcome back. Now to complete our discussion, talking about Greenwood Healthcare Specialist for Women. Joining me again, Dr. Calvin Monroe. Let's jump in. I want to talk about a couple of other things that women may come to you for, and what do you do and what do you expect? In sometimes the communities that you serve, and you may serve a greater population of women of color based on where you're located in the population. Diabetes, for instance, if a person is a diabetic, how are you going to work with them? How do you treat them either prior to pregnancy and during pregnancy?
Well, it's good you mentioned it. Preconceptional care is a big thing that tends to be ignored a lot, probably not intentionally, but a lot of women don't even think of seeing a doctor when it comes to planning a pregnancy. A lot of times it may not be planned to begin with, but the reality of it is that if you have chronic medical conditions such as diabetes and or hypertension or any other milieu of problems that could complicate the pregnancy, it's very beneficial to get into the provider early and start trying to get those things managed and under control. For instance, when you're dealing with diabetes, if the diabetes is very out of control, we use a lab test called hemoglobin A1C. It kind of gives us a quick peek at what your hemoglobin or what your blood sugars have been over the last 3 months or so. And if it's, say, 10 or greater, that denotes that you really haven't been taking care of yourself. You really haven't been doing the due diligence in terms of doing your day-to-day monitoring and taking your medicine as you should. But it can affect the fetus during development and cause a number of abnormalities to occur related to the heart and otherwise. So in terms of congenital deformities or problems, it can avoid, I mean, with management early in or before pregnancy, it can protect against that. It can protect against the mom having fetal loss as related to microvascular problems that can be caused by the diabetes.
Okay.
It can protect against moms having problems with superimposed problems like preeclampsia. Many things that can actually be avoided. Maybe not completely, but definitely the risk can be reduced substantially with preconceptional care and taking care of these chronic medical illnesses.
Okay, now you mentioned preeclampsia, and some people may say, whoa, wait, what was the clamp thing? Tell us, what is preeclampsia?
That's primarily a condition that preeclampsia, pre means before, eclampsia means seizure. Okay. And it's a condition that basically is unique to pregnancy, and it's common enough that a lot of our prenatal care is structured around it. The visits are structured such that as you start getting closer to the time of delivery, we start seeing you more frequently, and many times it's mainly to just check for this particular illness, which is one of the more deadly illnesses we deal with, secondary probably only to maternal hemorrhage. But it's a condition where the mom's blood pressures will spike, and they can spike so high that they can cause seizure, they can cause stroke, they can cause maternal and fetal death. It's it usually is a lot of different factors that can contribute to it. We don't really know exactly what causes it. Okay. We've been searching and researching for years. We know how to identify it. We know how to manage it. Usually management requires delivery in many cases. But it's a unique hypertensive condition that happens in pregnancy, and it basically can be very devastating.
Now let me ask this question, because some people have heard this as well, and clarify for us. Sometimes people will say, well, I wasn't a diabetic before I got pregnant and everything, then all of a sudden I developed diabetes. Tell us about that.
Well, in pregnancy, there's a hormone called human placental lactogen. It acts like insulin to some, well, it doesn't quite act like insulin, but it looks, in terms of its structure, like insulin. It's released from the placenta. It is released in great quantities, around 24 to 26 weeks. And it can sort of block the receptor sites, so the areas where the insulin is supposed to be having its effect on the cells in terms of being able to process glucose or sugars. And by it sitting there and blocking the doorway, it sort of allows the blood sugars to rise and cause this condition called gestational diabetes. Okay. And so it's it's common in the sense that it depends on a lot of different things, genetics, diet, socioeconomic status, things like that. But it doesn't happen with every pregnancy, of course. But it can happen with the subsequent pregnancy in some cases. With the first pregnancy, we screen for it because it's unpredictable in terms of when it's going to happen, basically.
Okay. Now, once a person has this gestational diabetes, people want to know, will I end up being diabetic? And or is every time I get pregnant, will I end up with this?
Well, the risk that you'll have in a subsequent pregnancy is increased. The risk, at least in the Hispanic population, the studies that I've read, I'm not sure. I'm sure it carries over to many different ethnic groups, but it's been demonstrated in specific studies that these women can and do develop diabetes later in life if the necessary diet, exercise regimens are not followed. Even if they are followed, sometimes the risk is demonstrated to be increased when they've had it during pregnancy to be able to develop just diabetes outside of pregnancy.
Okay, so in terms of how you care for yourself afterwards is very important to try to decrease that risk once you're exposed.
Correct.
What about the blood pressure issue for women that develop the high blood pressure during pregnancy? Again, they want to know, does that mean with every pregnancy that's going to be a risk, or does it also mean I'll end up with high blood pressure if I didn't have it before?
Well, it definitely increases the risk with each subsequent pregnancy.
Okay.
And whenever you have it the first time, we're always on a lookout for it developing again. And the person the condition is so unique that the person that develops it, I can't necessarily say has an increased risk outside of pregnancy. They may have a predisposition outside of pregnancy just due to genetics or diet and their habits, social habits. But I can't quite say, and maybe there's some studies out there, but I don't know of any that link specifically gestational hypertension or preeclampsia to chronic hypertension.
Okay. Okay. And once again, with the hypertension issue as a whole, there are certain things that we can try to do to minimize the risk factors of that. And if we do, to definitely take care of ourselves and do what we're supposed to do so that it doesn't get out of control.
Definitely.
Well, thank you so much for joining me. I'm so pleased that you're in our community with your facility and for Access for Women. Just thank you so very much, and I'm glad that you had a dream.
Well, thank you.
Well, that's our show. For Health Alert, I'm Pam Butler. I'd love to hear your questions, comments, or suggestions for future shows. Please write me at Health Alert USA, P.O. Box 50913, Tulsa, Oklahoma 74150. Or if you're on the email trail, please email me at healthalertusa@gmail.com. And also visit me on YouTube at youtube.com/HealthAlertUSA. And remember, get the medical care that you need, get the physicals and the annual checkups, and most importantly, and continue to dream and help your children to dream too. Take care.